Good morning. My name is Bryce DeCuzimano. I'm a nurse anesthesia resident here at National, and today I'll be presenting my anesthetic plan for a 28-year-old patient, male, who was involved in a high-speed MVA collision that's requiring surgical intervention. The patient presents to us with multiple life-threatening injuries, including a closed head injury, the GSC score of 13, an unstable pelvic fracture, a right femur fracture, some bilateral pneumothoraces with chest tubes placed in the field. He is hypotensive, 90s over 50s, with a tachy rate of 120, and has ongoing hemorrhagic shock. Anesthetic plan will focus mainly on the area management with C-spine precautions. Resuscitation efforts obviously will focus on hemodynamic optimization. My intra-op plan for anesthesia will focus mainly be on patient's immediate needs and preventing secondary complications. Post-operative planning will focus on pain control, readiness to extubate this patient, and also mitigating any PPCs like complication risk. So my first concern in the pre-op is securing the airway safely. I am assuming this patient has an unstable C-spine unless a head CT was done. I'll proceed as if he has a C-spine injury and use like manual inline stabilization techniques during my intubation sequence. I'll perform a modified rapid sequence intubation with using a video laryngoscope, minimizing neck movement, and to help with the goals emphasize on improving visualization and first pass success. If visualization is difficult, then I would use like a bougie as well. Given his bilateral pneumothoraces, I believe PPV must be carefully titrated to prevent any barotrauma. The patient is in a hemorrhagic shock, likely due to his unstable pelvic fracture, so that my goal is to restore perfusion without exacerbating any coagulopathy issues or secondary brain injury. Priority will be placed on blood products over crystalloids. We're using like a 1-to-1 ratio, PRBCs, FFP, and platelets to optimize oxygen delivery and prevent dilutional coagulopathy. TXA, obviously, per standard, will be administered within the first 3 hours to reduce fibrinolysis and improve clot stability. We're using like permissive hypertension with a MAP of 65 to preserve organ function and optimal organ perfusion and minimizing active bleeding. We'll place an arterial line to help with continuous BP monitoring, but as well as get labs like serial blood gases, lactates to guide our resuscitation efforts. In terms of my anesthetic plan, um, we'll be putting a greater emphasis on like neuroprotection, including IVCs, given his traumatic injuries, obviously blood loss, neurological considerations. I don't think like a regional anesthesia is appropriate at this point. You don't even have time for it. So I'm thinking more like GA route, which is basically going to help ensure that we can optimize cerebral perfusion, protect the brain, as well as maintain hemodynamic stability. So as far as induction strategy, we're preventing, my focus is to prevent hypotension, worsening cerebral edema, or any second brain injury. So using like ketamine 0.5 to 1 milligram per kg as my first line of choice for induction. Um, and etomidate 0.2 to zero point 0.3 milligrams will be the alternative if there's a concern for like ICP. Obviously, succinylcholine will be avoided due to risk of hyper-K, so I'm using rocuronium 1.2 milligrams per kg for my NMB for my intubation. In terms of maintenance strategy, I'm using like low dose sevoflurane 0.5 mac with opioid adjuncts like remifentanil, fentanyl to maintain hemodynamic stability and offer analgesia. Ventilation will be carefully tailored to like a PCO2 of 35 to 40, avoiding any hyperventilation, which could cause ischemia, or hypoventilation, which could increase our ICP. Um, the patient is going to require like really intensive intra-op monitoring to make sure that his TBI and hemorrhagic shock don't get worse. So an arterial line would be great for that. A CVC line, I'll place that as well for if vasopressors are required. Some serial ABGs, lactate levels, we'll be getting like the TEG levels to guide our resuscitation efforts as well. I will implement a massive transfusion protocol with significant hemorrhagic risk. Obviously, we will be doing again the 1-to-1 ratio. Calcium chloride will be administered just to counteract the citrate-induced hypocalcemia. We'll be using active warming measures to make sure we keep the patient warm enough to prevent acidosis, hypoxemia, etc. TBI injury risk that I talked about, obviously, we need to make sure we maintain normal capnia, PCA2 of 35 to 40 to prevent any exacerbation in the brain. We're avoiding excessive fluid resuscitation to prevent edema. Blood products will be my primary resuscitation efforts over crystalloids to prevent the dilution, coagulopathy. If hypotension does persist, obviously we'll be implementing vasopressors like norepi as well. In terms of post-op considerations, the patient is going to be in a lot of pain, so we're going to use a multimodal approach. We'll be using like IV acetaminophen. We can use some ketamine, zero point 0.2 to zero point 0.5 milligram per kg per hour infusion for analgesia, just in the intra-op to PACU or to ICU, DCing it there, and then starting like a fentanyl drip or a fentanyl drip, PCA, to help out. In terms of extubation criteria, we're assessing for neurologic and respiratory function for this patient. So I want a GSC score of over 8, adequate spontaneous breathing like tidal volume, respiratory rate, etc. Um, Vitals are stable. There's no deterioration of neurology at all. And then we extubate. Post-op complications obviously will be hemorrhage, some DVT, possible ARDS or infection risk. So measures will be taken to take care of that as well. Um, what else can I think of? I think that's pretty much it, really. Obviously, with the infection risk, we're going to be administering antibiotics. For hemorrhage, we'll be using those measures I spoke about. For ARDS, we're using like lung protective measures, ventilation, like on the ventilator to make sure that we mitigate any risk for PPCs that I spoke about. Um, like Lactasis. Yeah, and I think that's pretty much it. Thank you so much, and I welcome any questions.